Thank you, Dr. Ledley, Dr. Hong. I'd like to thank the organizers of the Asia Pacific Cardiovascular Intervention Symposium for inviting us and for organizing this joint Sejong-Drexel Symposium. So I'm going to talk about the current status of cardiac transplantation and post-transplant immunosuppression. I'm not going to discuss biomarkers. I'm going to talk about how we treat these people. I have no disclosures. I'm going to talk about the off-label use of Sirolimus and Everolimus. These drugs are not approved in the United States by the FDA for the treatment of patients with heart transplants. So cardiac transplantation is one of the two oldest therapies for heart failure. The other one is digitalis glycosides. But next year will be the 40th anniversary of cardiac transplantation. December 1967, Christian Barnard performed the first transplant in South Africa, and nearly 50 years later, there have been over 100,000 transplants. I won't go through the kind of sorry story of the early days of transplant. It was really a very difficult period. But what you can see here is that in the past 30 years, the number of transplants have increased significantly. There was a dip in the late 1990s, early 2000s as a result of a drop in the number of patients on the list because of new therapies like cardiac resynchronization therapy, and also a drop in organ donation. And the current trends in the United States for transplant are that patients are sicker. They're older. They're sicker at the time of transplant. They are emergent status, status 1A, because that's the way you get transplanted, is to be at the top of the list. There are more women, and there are more patients on mechanical circulatory support. In our center, about 80% of patients who are transplanted are on bridge to transplant, and in the Philadelphia region, it's about 40 to 50%. This shows the donor age in the United States and in the ISHLT, and it's been relatively stable over the past decades. Interestingly enough, the average age of a donor in the United States is in the early 30s. In Europe, donors are in the mid-50s. They have an older population, but they use older donors who would be turned down by us. And these are the major post-transplant complications, the things we have to worry about once we do a transplant. So rejection, infection, cardiac allograft vasculopathy, malignancies, and then the complications of the medications that we use, hypertension and nephrotoxicity. This is good news. This shows that over time, survival of patients from the early modern era when cyclosporin was introduced to now has improved significantly. But if you look at this, it's really in the first 6 months to 1 year. So our improvement in post-transplant care is due to better ICU care, better treatment or prevention of rejection, and better treatment or prevention of infection. And if one goes beyond the first year, you still see that there are causes of decreased survival over time. So there are bad things happening in these patients beyond the first year post-transplant. What kills people over time? In the first year, it's mainly rejection or infection or nonspecific graft failure. But beyond the first year, it's malignancy and cardiac allograft vasculopathy, the transplant coronary disease. And that's shown here too. Red is cardiac allograft vasculopathy, and green is graft failure. Well, graft failure beyond the first year post-transplant is due to transplant coronary disease. And you also see malignancy here. Those are the major causes of death beyond the first year post-transplant. And in this complicated slide, we see that there's an accrual in terms of the percentage of patients who develop cardiac allograft vasculopathy, forms of malignancy, and that these are the major causes of death when we get out to 16 years, 10 to 16 years, 6 to 10 years, and even within the first 5 years. So the immunosuppressive agents that we use, the standard triple therapy is calcineurin inhibitors, cyclosporin, and tacrolimus, which inhibit T-cell proliferation and activation via inhibiting calcineurin and IL-2 expression. These are the cornerstone drugs that have allowed transplantation to develop and progress. Then we also use anti-proliferative drugs, mycophenolic acid and azathioprine, inhibit T-cell proliferation via inhibition of purine synthesis. And then finally, we also use corticosteroids, we tend to wean corticosteroids off within the first 6 months post-transplant because of their multiplicity of side effects, but they have a wide variety of effects. They inhibit cytokine elaboration, lymphocyte circulation, T-cell proliferation, a variety of effects. There's going to be a quiz on this later on, so everybody pay attention. This is a very good paper by Phil Halloran from 2004, which goes through all the mechanisms of the immunosuppressive agents. So you see cyclosporin and tacrolimus here, inhibiting production of interleukin-2. You see mycophenolate and azathioprine here to inhibit nucleotide synthesis, and then what are called the mTOR inhibitors, sirolimus and everolimus, which inhibit this protein, which is involved in cell proliferation. Now, how does all this get started? The antigen-presenting cells up here present fragments of the foreign antigen, foreign HLA, to the T cells, and the T cells recognize this in conjunction with the T cell receptor and with a number of other molecules, including these secondary signals. These are crucial. That causes activation of calcineurin and then production of interleukin-2, which then binds its own receptor, causes proliferation of T cells, activation of T cells, and the whole cascade begins. And this is the same thing here. T cell receptor, antigenic signal, IL-2 receptor, activation of the T cell, including proliferation, where we can inhibit with anti-proliferative agents like the mTOR inhibitors, mycophenolate, or azathioprine. So the newest class of drugs that we use are the mammalian target of rapamycin, or mTOR inhibitors, also known as proliferation signal inhibitors, which inhibit T cell proliferation, but also inhibit vascular smooth muscle cell proliferation, which is a response to endothelial injury. And you may recognize some of these like sirolimus and everolimus because they're used in drug-eluting stents to inhibit proliferation in response to the injury created by stent deployment. And here's where they work. They bind to the same molecule that tacrolimus binds to, but they inhibit mTOR. mTOR is involved in proliferation of a wide variety of cells. It's also involved in proliferation of malignant cells, which is why this class of drugs is used in much higher doses than we use in transplant as adjuncts to control malignancies. There also are agents called that we use as adjunctive therapy, antibody therapy for induction therapy. And the most commonly used ones are anti-IL-2 receptor antibodies. Basiliximab is the one that's most common. Prevents IL-2 from binding to its receptor, prevents T-cell activation. Anti-CD3 antibodies we don't use anymore because of their frequent and severe side effects. And then anti-thymocyte globulin is one that's commonly used. Inhibits a variety of T-cell activities. These are usually used in the first few days post-transplant so that the initiation of calcineurin inhibitors, which are nephrotoxic, can be delayed. So let's talk about the problems post-transplant. There are actually two types of rejection. Antibody-mediated rejection is kind of the stepchild we don't think about very often, but can be very severe. And it has a bimodal incidence. It can occur within the first few days post-transplant. If it happens then, it's usually very severe, and you didn't really do your homework to make sure that the patient was not sensitized to the antigens of the donor. And what we do is we will do what's called a virtual cross-match, which means that we are aware of which antigens, proteins on the surface of the transplant, our recipient is sensitive to, and we will not take donor hearts with those antigens. Then there's a later form of antibody-mediated rejection where the patient develops antibodies, what are called donor-specific antibodies against the antigens on the surface of the transplanted heart. And so how do we diagnose this? Well, we look for antibody staining of endomyocardial biopsy specimens. We look for evidence of complement fixation, which is how the antibodies damage the allograft. And we look for evidence of macrophage infiltration with this staining, CD68. C4D is staining we look at with immunochemistry or immunofluorescence. There also are other antibodies to make things more complicated. Non-MHC antibodies that can also cause antibody-mediated rejection. We tend not to look at them as frequently because there's so many of them, you can't screen absolutely everything. But this is how this works. These antibodies bind to the antigens on the surface of the transplanted organs and activate complement, or they attract macrophages, which then damage the transplant. And there's a gradation of how this develops. There's a subclinical form where people have donor-specific antibodies, the graft function is fine, then you do biopsies and you may find evidence of complement fixation and antibody deposition, but the patient's fine, no symptoms, and then the patient clinically becomes symptomatic with graft dysfunction, symptoms of heart failure, and this is where we intervene. Usually we try to remove the antibodies with plasmapheresis. We shut down antibody production with IVIG, and we may use other agents too, anti-lymphocyte agents. And there's a thought that the chronic appearance of this disease can result in cardiac allograft vasculopathy and some of the other things we see, chronic graft dysfunction and restrictive cardiac physiology. This is what we're talking about. This is infiltration of macrophages, and here we see staining of complement, and a little bit weaker a week later. And this is immunohistochemistry and immunofluorescence, looking at fragments of complement C4D, C3D. And it's basically a percentage of the number of vessels. The more vessels that are stained, the worse the antibody-mediated rejection. And here again, we see C4D, C3D, and an antigen on one of the macrophages also stained. This is the ISHLT nomenclature, where really you don't initiate treatment unless you have graft dysfunction. There are some people who believe that if you see anything abnormal on the biopsy, like immunofluorescence of complement, that you should initiate therapy. There are no data to support that, because the therapy you use to treat antibody-mediated rejection is very intense. So there are no data that just treating the biopsy alone without graft dysfunction offers any benefit in terms of outcomes. And when we think about rejection, most commonly we think about cellular rejection, which begins within the first few days post-transplant, and it can occur most commonly in the first 3 months, then 6 months, then first year. And this is the T-cell mediated attack on the transplant, mediated by helper T cells, cytotoxic T cells. They respond to immune recognition called signal 1. Signal 2 is where there has to be a secondary recognition between the antigen-presenting cell and the T cell. If you don't have that recognition, the T cell shuts off. So that has to happen. Signal 3 is when IL-2, which is produced by the activated T cell, stimulates its own receptor, which then causes T cell proliferation and activation and destruction of the allograft. So here we are, calcineurin, which is a promoter for the IL-2 gene, and if it's not inhibited by tacrolimus or cyclosporin, you get production of interleukin-2, binding the receptor and stimulation of the T cell. We've seen this before. So, cellular rejection within a few days of transplant, cell-mediated response to donor MHC antigens, which causes damage to the endothelium and to the myocytes. And we actually can grade this by biopsy. Our gradation system, and this is the current one that we use, is based on the amount of myocytes damaged and the amount of lymphocytic infiltration, or whether there's hemorrhagic infiltration. And 2R and 3R is where we initiate therapy, usually with high-dose corticosteroids, or if there's graft dysfunction or hemorrhage, with antibodies, anti-thymocyte globulin. These are biopsy specimens of mild 1R. We would not treat here. You see the lymphocytes around this blood vessel scattered through the myocardium and here as well. And here's where we would treat. This is a grade 2R, where there's more extensive lymphocyte infiltration and myocyte necrosis, even more extensive lymphocyte infiltration and myocyte necrosis, and then this is frank hemorrhage within the myocardium. This is an emergency here. So, patients who have rejections, a treated rejection, any treated rejection, have a worse outcome than patients with untreated rejection. The fortunate thing is we're seeing much less rejections than we used to see. On average, we used to say, well, about 50% of patients would have a cellular rejection in the first year. I'd say the percentage is probably closer to 5% at this point, probably because We're using tacrolimus instead of cyclosporin, mycophenolate instead of azathioprine, and we're getting smarter at how we use immunosuppression. And this shows the improving freedom from rejection over time. This is the most recent era, and this is about 20 years ago. So our long-term challenges are to manage the renal failure and metabolic adverse events from our immunosuppression, to mitigate cardiac allograft vasculopathy, and to try to prevent or treat malignancy. This slide shows renal dysfunction, so you can see a significant percentage of patients within 10 years post-transplant will have elevated creatinines. Some will be on dialysis, some will need renal transplants. And I think that this has actually improved significantly because we've been much more aggressive at reducing cyclosporin and tacrolimus levels beyond the first year post-transplant. Our thought used to be, well, look, the heart's more important than the kidneys, and having a creatinine of 2, 1 year post-transplant is the cost of doing business for keeping people alive. We're much more careful and much smarter than we used to be. And this is from Oho's important study in 2003, published in the New England Journal, showing that there's a progressive increase in chronic renal failure in patients with heart transplants or other non-renal transplants. So we see this much less frequently, and we're much more willing to even get people off of calcineurin inhibitors by adding sirolimus or everolimus and also using mycophenolate together, and that will reduce the creatinine. And so you can see in the past 15, 20 years, we've been much more successful at improving the freedom from severe renal dysfunction, which is defined as a creatinine above 2.5. So malignancy is the other big issue, and malignancy can be pretty widely defined. There are unique malignancies that occur post-transplant. There's post-transplant lymphoproliferative disorder, which can turn into a monoclonal lymphoma. The most common kind of malignancies are squamous cell carcinomas. We have a lot of patients who are very fair-skinned, who were exposed to the sun when they were little kids, not thinking they'd ever need a transplant, and they have to be very carefully managed. We have a transplant dermatology clinic where these people come in every quarter and have their skin examined, and once squamous cell carcinoma is identified, it's removed very aggressively. Fortunately, we have not seen an increase in melanoma, melanoma would be a problem. It's very common to see that in Australia, though. Melanoma is a big problem among Australian transplant patients. And then in terms of other cancers, the majority of them, the things we think about like bladder cancer, breast cancer, prostate cancer, are not more common in transplant patients, but when they occur, they can be more aggressive. So I think we're doing maybe a better job of preventing malignancies or identifying them early on. But there are a lot of questions. So, for example, what's the relationship between different immunosuppressive agents and cancer risk? I'll discuss this at the end of my talk. How about the duration and intensity of immunosuppression and cancer risk? The longer you use high-dose immunosuppression, the more likely you are to develop malignancy. What's the efficacy of low or minimal immunosuppressive regimens in preventing malignancies? And then we generally use the American Cancer Society screening protocol, but should we do that? Should we screen more frequently? What are the components of cancer screening? So, for example, we have not abandoned the use of the prostate-specific antigen because many of our patients are African Americans and prostate cancer is more common, and when it occurs in transplant patients, it can be very severe. And we've actually done prostatectomies in people on inotropic therapy who were going to be listed for transplant. And what about, for example, doing CT scans in patients who were smokers in the past to identify small, potentially malignant lesions and get rid of them before patients get transplanted? I mentioned patients are sicker now on the list. You can see this is the ISHLT, the gradual increase in the use of mechanical circulatory support. It's about 50% worldwide. In our region, it's over 50%. At our institution, it's about 80%. And if one looks at survival, overall, with the standard ventricular assist devices that we use, continuous flow and pulsatile flow, there's no difference, significant difference in terms of outcome, except the pulsatile flow, the old HeartMate 1 provides a worse outcome, and ECMO provides probably the worst. These are the induction immunosuppressive agents that are used. The major ones that are used, the anti-IL-2 receptor antagonists. And this is the current status of immunosuppression now. You can see that tacrolimus is used much more frequently than cyclosporin, and azathioprine has virtually disappeared. There still are patients receiving prednisone. We have virtually no patients receiving prednisone beyond the first year post-transplant. We work very aggressively to get our patients off prednisone. So let's talk about some of the major challenges to long-term survival post-transplant. This is cardiac allograft vasculopathy, one of our patients, transplanted with a heart from an 18-year-old with normal coronary arteries at the time of discharge after transplant, came in 1 year post-transplant with heart failure and had a sudden cardiac arrest, and this is his LAD. So within the space of a year, he had near total obliteration of his coronary artery. What causes this disease? This starts actually at the time of organ harvest. Ischemia when the heart is ex vivo, and then reperfusion injury when the heart is reconnected, and there's a cascade of immune and non-immune factors, complement inflammatory mediators, and cytokines that damage the endothelium and cause smooth muscle cell proliferation, which is the response of the smooth muscle cells to damage the endothelium. It occurs in about 40% of patients at 5 years post-transplant. A diffuse disease involving the entire coronary tree may be associated with CMV, loosely associated with classical atherosclerotic risk factors, and histology resembles smooth muscle cell proliferation of restenosis. Survival at 3 years is 60 to 80%. Severe disease defined as 3 vessels with greater than 40% stenosis has a 6% 3-year survival. And death is usually due to sudden cardiac death, MI, or heart failure. Ischemic events are usually silent. Percutaneous options are difficult because the distal vessels are very small, so patients don't do well with CABG, and there really is not a lot of benefit with PCI either. We have seen an improved freedom from cardiac allograft vasculopathy, and I'll tell you why that is the case. Patients with cardiac allograft vasculopathy have a worse outcome long-term than those who don't. And this is an example of an angiogram. You can see near obliteration in 2 years of the proximal and near proximal vessels in this patient. Nothing else really does that. Even severe diabetes doesn't do that. So here's everything that we think is involved in causing this disease. Whenever you see a slide like this, it means we really don't know. But I think the thing that we can say is that it's the sum total of injuries to the transplanted organ that causes cardiac allograft vasculopathy. And these are the different types of injuries. So there are immune factors, non-immune factors, inflammation, and that results in what we see here in intravascular ultrasound, which is this intimal thickness. That's cardiac allograft vasculopathy. And we use IVUS not really clinically because insurance companies don't pay for it, but as a surrogate marker in clinical trials because we can get the information relatively early, like within a year post-transplant. So angiography is the most commonly used modality. It's the modality that is used to define the severity of cardiac allograft vasculopathy by the ISHLT. We don't know at this point whether that corresponds into worse outcomes, but we do know that it's relatively insensitive. Here's a patient who died shortly after a normal coronary angiogram, and here you see this eccentric plaque. Here are 2 IVUS images in normal-looking coronary angiograms. Relatively little intimal thickening here, but extensive intimal thickening here in this area that looks normal. So what parameters do we use? We use volumetric parameters. The most robust predictive parameters, maximal intimal thickness, change in maximal intimal thickness from the baseline IVUS right after transplant to the IVUS 1 year later. How do we know that? There have been a number of studies, Oxner, Stanford, Cleveland Clinic, showing that changes, really subtle changes from 0.3 to 0.5 millimeters, maximal intimal thickness from baseline to 1 year can predict bad outcomes 4 years later, heart failure, MI, sudden cardiac death. Here's an example of what we're talking about. No intimal thickness here, and then all of a sudden here, a change greater than 0.5 millimeters. From the Cleveland Clinic, patients with those kind of changes had a worse outcome in terms of all-cause mortality and the combined endpoint of death and myocardial infarction. There was a multi-center study looking at IVUSs that were obtained for clinical trials and defining patients into those with changes in maximal intimal thickness greater than 0.5 millimeters or less than 0.5 millimeters. And those with the changes greater than 0.5 millimeters more likely to die or have graft loss at 5 years, more likely to have major adverse cardiac events, and more likely to have angiographic disease than those with less of a change of maximal intimal thickness. The greater the change in maximal intimal thickness, the more likely the cardiac events. Now, why do we see less cardiac allograft vasculopathy? That's from these early studies. This is the pravastatin study. Patients randomized to pravastatin showing improved survival, less CAV, and less rejection mortality, and less disease by IVUS. And then with simvastatin, the group in Germany showed the same thing. So this is the one Class 1 level of evidence A recommendation in the ISHLT guidelines. Everybody, regardless of their lipid profile, should get statins post-transplant. What about the use of mycophenolate mofetil, CellCept versus azathioprine? This was a randomized trial which showed some significant benefits in terms of reduction of mortality, reduction of rejection with hemodynamic compromise. But in terms of benefits for cardiac allograft vasculopathy, they were really equivocal. So where have we had some gains in terms of our ability to mitigate cardiac allograft vasculopathy? It's been with the mTOR inhibitors. And there have been a number of clinical trials looking at that. Here's mTOR, which causes proliferation of a variety of cells, including smooth muscle cells. So one of the first studies was the Australia-New Zealand study looking at sirolimus, 2 doses of sirolimus versus azathioprine. Primary endpoint was 6-month incidence of biopsy-proven rejection, a number of secondary evidence, and they also endpoints. They also looked at IVUS change from 6 weeks to 6 months. And what they saw, less rejection. They saw an elevated creatinine, and that's an important issue that we're going to have to discuss. It's a recurrent motif. And in red, they saw greater progression of cardiac allograft vasculopathy in the azathioprine group and much less in the sirolimus group. So in summary, sirolimus seemed to reduce cardiac allograft vasculopathy progression, reduced rejection, but serum creatinine was higher in these patients. Then there was another trial, the everolimus trial. Everolimus is also called RAD, which I was fortunate enough to lead. That was every place but New Zealand and Australia. This is our composite endpoint, which showed a reduction in the composite endpoint in 2 RAD doses compared to azathioprine. And that benefit was due to a reduction in the frequency of grade 3A or 2R rejection with everolimus. We actually had an IVUS arm as well to see the effect on cardiac allograft vasculopathy. And the progression of change in average maximal intimal thickness was reduced in the everolimus groups compared to azathioprine. And in a number of volumetric assessments, we also saw that. We defined the incidence of cardiac allograft vasculopathy as a change in maximal intimal thickness greater than 0.5 millimeters from baseline to 1 year. And the incidence was less in the 2 everolimus groups compared to the azathioprine group. We published this in 2003 in the New England Journal of Medicine. So there were some problems with that study. First of all, azathioprine was the comparator because that was the only drug available in most of the centers, in most of the countries involved in the clinical trial. And now we use mycophenolate, a more potent immunosuppressive agent. And in addition, we also saw an interaction between an elevation of creatinine in the patients who received everolimus compared to patients who received azathioprine. So we did another study comparing to mycophenolate, and we also had a strategy where this is the largest clinical trial ever done in cardiac transplantation, 63 centers, 14 countries around the world. We made an effort to reduce the amount of cyclosporin, the target dose that patients getting everolimus received, so that we could reduce the severity of renal dysfunction. So mycophenolate, they received standard dose cyclosporin. Everolimus, we reduced it very quickly. And the bottom line was that the primary endpoint, which was similar to the previous primary endpoint I showed you, there was no difference in terms of any of the components, including rejection. See that here, no difference in rejection. There was greater mortality at 1 year in the patients receiving everolimus. And by year 2, that had equaled out, but within the first year, it became apparent that patients had more infections in the everolimus group. And so we tried to look into that to figure out what that was from. Sure enough, patients receiving induction with thymoglobulin were more likely to die of infections. So you can actually over-immunosuppress patients. That's something we've known for many years, and that's what we saw here as well. We also identified 2 groups of patients who do very poorly with this drug, people with low GFR at baseline prior to transplant, and patients with infected ventricular assist devices did poorly. We had an issue with the transplant survival in one of the countries involved in the study. So sometimes you read about what's called a center effect, where the overall results can be distorted because of bad outcomes in a center. So we had a country effect, and I won't mention the country by name, but it's a European country between France and Poland, Switzerland and Denmark. You can look on Google Maps. At the time of the clinical trial, they had a 1-year transplant survival of 64%. So that adversely affected our outcomes. And there was worse renal function in the group of patients getting everolimus compared to MMF. And that was because people had a lot of difficulty reducing the cyclosporin doses that patients getting everolimus, they had a lot of difficulty wrapping their arms around that. However, if you use the appropriate everolimus reduction in cyclosporin doses and trough levels, you had no difference in renal function. The other concern with these drugs is wound complications. And when my paper in everolimus came out in 2003, a number of centers started using Sirolimus as de novo immunosuppression, Stanford, University of Minnesota, Newark Beth Israel, and they found a very high frequency of wound dehiscence and mediastinitis, which we did not find, fortunately, in this study. What we did find was frequent pericardial effusions requiring pericardicentesis, pericardial window. And so if you use this drug de novo, you have to be careful. You have to do an echo to make sure that you've identified the pericardial effusions. And then there was an IVUS sub-study. And what this showed was a dramatic reduction in the incidence of cardiac allograft vasculopathy and significantly less progression of cardiac allograft vasculopathy as reflected by change in maximal intimal thickness from baseline to month 12. And if one looked at volumetric indices, these also were less likely to progress than in the MMF group. So in summary, everolimus was more effective than MMF in mitigating progression of cardiac allograft vasculopathy, reducing the incidence, and this was irrespective of gender, diabetes, age, presence of donor disease. However, you can over-immunosuppress patients, and that can kill them due to infection. You have to be careful. And there was no difference in terms of rejection. Additionally, if you're going to use these drugs, you have to reduce the trough cyclosporin levels. That's critical. We move on. Now, there's another alternative strategy or alternative strategies for using this drug. This is from a Scandinavian study called the SCHEDULE study, where what they did was from week 7 to 11, they completely withdrew cyclosporin. They had people on everolimus, MMF, cyclosporin, and corticosteroids. They completely withdrew cyclosporin, and the control group, they continued cyclosporin with MMF and corticosteroids. What they found here was that there was no worsening of renal function. They found a little more acute rejection in the everolimus group once they were off cyclosporin, and they had to treat them, and some of them they had to put back on cyclosporin. But most interestingly, they found that there was less progression of cardiac allograft vasculopathy in the everolimus patients without cyclosporin than in the controls. Looking at change in maximal intimal thickness and also volumetric assessments. And the incidence was less in the everolimus group too. So what you can actually do is you can actually eliminate the calcineurin inhibitors early on and prevent the problems with renal dysfunction, and also prevent or mitigate the development of cardiac allograft vasculopathy. Now, there's yet another strategy that the Mayo Clinic has used, which is to start Sirolimus about a year post-transplant. If you start it 2 years post-transplant, it doesn't have a benefit. So they looked at one group and did IVIS from when they started it to 1 year later, and another group that they did not make these changes. And sure enough, patients who got Sirolimus had less progression of disease than patients who remained on calcineurin inhibitors. And this is actually very encouraging because our strategy for treating renal insufficiency in patients 1 year post-transplant who have elevated creatinines and are on calcineurin inhibitors is to put them on sirolimus plus mycophenolate and withdraw these calcineurin inhibitors. And they showed that there was less progression of disease in the patients receiving sirolimus and greater freedom from cardiac allograft vasculopathy. So what do we do about people with established cardiac allograft vasculopathy, the tens of thousands of patients who already have this disease? A vexing problem. This is Dr. Mancini's study from Columbia where she had patients with established disease and she randomized them to either continue an immunosuppression or that they were on or receive sirolimus. And they developed a catheterization score finding that the patients on sirolimus had less progression based on angiography than the patients who were in the control group. And if one looks at a composite of death, acute MI, need for PCI or bypass, or a change in catheterization score, there was greater freedom from that in the sirolimus group than the control. So we routinely will switch patients or add mTOR inhibitors in these patients because we really don't have anything else to offer. But this is the data that justifies that. So mTOR inhibitors or proliferation signal inhibitors reduce the rates of CMV, reduce the incidence and severity of cardiac allograft vasculopathy, allow reduction of calcineurin inhibitor target trough levels. They may reduce the incidence of malignancy. Let me show you that. Sirolimus can adversely affect wound healing. They potentiate nephrotoxicity of calcineurin inhibitors. They're associated with an increased risk of bacterial infections, but if you use additional immunosuppression like anti-thymocyte globulin, increased risk of infection, increased serum triglycerides, and you also have to watch out for pericardial effusions. So what about their benefit in malignancies? Well, this is not in heart transplants. This is from a big registry in the United States called the SRTR, which is in all transplants, mainly in renal transplants. And this shows patients who just were receiving mTOR inhibitors alone had a significantly lower rate of malignancies than patients receiving calcineurins alone. And patients receiving mTOR inhibitors plus calcineurin inhibitors also had a reduction compared to calcineurin inhibitors alone. We see this here as well. So perhaps this is something that we should do in patients who develop malignancy. And again, we default to that when patients develop malignancies. And how are patients doing post-transplant? Well, the vast majority have an excellent functional status. And these are people who were severely debilitated pre-transplant. And the employment status is also significantly improved. A lot of these people end up who had retired or were not working were able to go back to work. So Gamsahamnida, thank you very much for your attention.